second half of Landmark Changes in Asthma Management. My name is Dorothy Pardalis. I am a community pharmacist in Windsor, Ontario, as well as a certified respiratory educator working in the lung health program at the Tilbury District Family Health Team. This portion of the program will focus on the valuable role of pharmacists as key partners in asthma care. In terms of disclosure, I have worked with various pharmaceutical companies listed on this slide. As well, I have received a speaker's fee from OPA for this learning activity. This learning activity has also received financial support from AstraZeneca in the form of an educational grant. Upon completion of this presentation, you as a pharmacist should be able to assess the level of control of your asthma patients, identify opportunities in the pharmacy to optimize asthma control for your patients, list common drug therapy problems in your patients with asthma that may lead to an increased risk of exacerbations, apply strategies to effectively assess, intervene, and partner with your patients and their healthcare providers to improve their asthma care. Many of our patients with asthma have gotten used to living with daily symptoms, nighttime awakenings, exercise limitations, and lost productivity. Healthcare providers, including pharmacists, can educate our patients that good control of asthma can mean living symptom-free. That means zero symptoms, zero nighttime awakenings, zero time lost from school, work, or play, and zero exercise limitations. It is, however, very important to identify each individual asthma patient's goals and concerns and work together to achieve those goals. Asthma patients will still experience triggers and times when their asthma symptoms increase. However, the recognition that they can prevent and minimize the disruption to their lives and increase their quality of life can be very motivating for patients. Using the tools in this presentation, pharmacists can identify those patients who are not in good control and start the conversation on how they can aim for zero. Let's look at how our asthma patients in Canada are doing in terms of achieving well-controlled asthma. The vast majority, 93% of Canadians with asthma, believe that their asthma is well controlled. The reality, however, is that only 10% of Canadians are well controlled, according to the Canadian Thoracic Society guidelines. 41% of Canadian asthma patients do not exercise at all due to their asthma, and 33% miss school, work, or other social activities due to their asthma. As healthcare providers, we have some work to do in terms of helping our asthma patients recognize what good control means and facilitate the process towards better control. Dr. Ellis described the Canadian Thoracic Society's guidelines for good asthma control. The two parameters we will focus on are daily symptoms and the use of short-acting beta agonists or rescue medication. As you can see, according to the CTS, a patient should be experiencing daily symptoms less than 4 days per week and should be using less than 4 doses per week of beta agonist medication. It is also very important to note that the regular need for reliever to treat or prevent exercise-induced symptoms is defined as suboptimal control. The GINA guidelines look at the patient's symptoms in the last 4 weeks. A patient is well controlled if they meet all of the following parameters: daytime symptoms less than twice per week, they require the reliever less than twice per week, they do not wake up at night and do not experience any activity limitation. Note that GINA also divides patients into 3 categories: well-controlled, partially controlled, and uncontrolled, based on the number of these parameters that they successfully meet. The Asthma Control Check is an excellent tool developed by the Ontario Lung Association. It can be downloaded free of charge. This tool uses the CTS criteria for well-controlled asthma and helps to initiate dialogue with patients regarding their symptoms, level of control, and ways to achieve better control. Now we are going to look at how SABA, or reliever use, is a key marker of asthma control. There are 2 short-acting beta agonists or relievers used in Canada, salbutamol meter dose inhaler, and terbutaline dry powder inhaler. This slide calculates the number of canisters of short-acting beta agonists that a patient should be filling per year if their asthma is well controlled. On the left side, using the GINA recommendations, patients should be using SABA less than or equal to twice weekly, which equals 1 to 2 inhalations twice a week, equals 2 to 4 inhalations per week, times 52 weeks is equal to 104 to 208 inhalations per year. Because each MDI has 200 doses, this equates to half to 1 canisters per year. On the right side, using the CTS guidelines, patients are to use less than 4 doses weekly. This equates to 1 to 2 canisters per year. Therefore, a patient with well-controlled asthma should be using less than 2 canisters of SABA MDIs per year. Note that the SABA dry powdered inhaler terbutaline only has 100 doses, so patients should be using less than 4 dry powdered inhalers per year. To review, we know that SABA or reliever use is a key marker for asthma control, and high use of SABA is a modifiable risk factor for exacerbations, even in patients with few symptoms. Good control means less than or equal to 2 MDI canisters per year or less than 4 DPIs per year. Patients using greater than or equal to 3 MDI canisters per year, which is an average of 1.7 puffs per day, is associated with a higher risk of hospitalizations. Dispensing of greater than or equal to 12 canisters per year is associated with a higher risk of mortality. Which health professional should be the gatekeeper or guardian for SABA use? All health professionals on the asthma patient team should be looking at how much SABA a patient is using. However, pharmacists are an ideal health professional to be a gatekeeper or guardian for SABA use, as they have access to the patient's medication profile. Pharmacists are also very accessible and see patients often to be able to regularly assess SABA use. From these points, greater than or equal to 3 canisters per year puts patients at risk of exacerbation and hospitalization. Therefore, pharmacists should ensure that patients are using less than 3 canisters of MDIs per year. The unique role of the pharmacist is to identify, resolve, and prevent drug therapy problems. We will now discuss common drug therapy problems identified in asthma patients. We know that uncontrolled asthma symptoms are an important risk factor for exacerbation. The first common drug therapy problem is that the patient is experiencing poor asthma control and at risk of exacerbations secondary to underusing controller therapy. What are the reasons why patients are underusing their controller therapy? The patient may forget to take their medication. The patient may lack education regarding importance of controlling inflammation. The patient may be experiencing some adverse effects such as thrush or sore throat. The patient may be unable to use the medication as directed. For example, improper inhaler technique or difficulty achieving adequate drug delivery to the lungs with the inhaler that they're using. The patient may require dose adjustment. The patient needs additional therapy but is not receiving it. Patients who are experiencing an increased frequency in symptoms, who are adherent and using their inhalers effectively and have good environmental control may require step-up therapy. For example, the addition of a long-acting beta agonist. Untreated comorbidities can also lead to poor control of asthma. For example, GERD, rhinitis, and sinusitis can all be effectively treated with medication and can result in better control of their asthma. Note that triggers and environmental control are also very important factors to consider. For example, exposure to an allergen domestically, for example, a cat allergy with cat in the home, or a patient who's a smoker or is living with a smoker, puts patients at risk of poor asthma control. Patients will require pharmacotherapy, such as an antihistamine, but others may just need education surrounding trigger avoidance and changing their environment to lessen the negative impact on their asthma. What is the role of the pharmacist in terms of drug therapy problems? The first step is to assess the patient and identify any drug therapy problems. The second step is working together with the patient to develop shared goals. The ultimate goal is for the patient to attain good asthma control, decrease their risk of exacerbations, and enjoy a better quality of life. Let's meet Judy. Judy is 23 years old, working as a laboratory technician. She is a non-smoker. Her physician diagnosed her with asthma 2 years ago after the onset of regular wheezing, cough, and shortness of breath. She was prescribed fluticasone propionate, 100 microgram discus, 1 puff BID, and salbutamol MDI, 2 puffs every 4 hours PRN. Today, Judy is asking for a refill for her salbutamol inhaler. Let's look at assessment. Does the patient have an asthma diagnosis? Ask your patients, has your healthcare provider told you that you have asthma? Have you ever had spirometry or a breathing test? If yes, when? Pharmacists also need to assess if the patient's asthma is in good control. There are several ways to assess control. As mentioned, we can use the asthma control check. We can also ask the patient whether they're using their SABA or reliever greater than or equal to 3 times per week. And lastly, we can assess the number of SABA canisters used yearly. We will now introduce you to a valuable quick tool called the slide rule, which will help you assess yearly SABA use by your asthma patients. Knowledge check question 1. A patient is not in good control if using greater than or equal to how many salbutamol canisters per year?